Hi, everyone, and thank you for joining us. I'm Paige Minnemeyer, Senior Editor for Fierce Healthcare, and I'm here with Andrew Toy, President and Chief Technology Officer at Clover Health. We're going to dig into why the Clover team views broad networks as key to its strategy. Andrew, thank you for joining us.
Glad to be here. Thank you.
Awesome. So, as we just said, you and your team really view broad networks as a critical piece of your strategy in the market. I mean, why is that, and where are you seeing that pay off?
Absolutely. So, as many people might know, the theme in healthcare right now is towards narrower networks, right? And the view is that when you narrow your network, you can select doctors who provide higher quality care and therefore provide better care. And that's how you manage care within the network of doctors. And there's nothing wrong with that philosophy. The orientation of value based care is around that philosophy. However, I think that what you also see is that the clue is in the name. Narrow networks are narrow. They, by definition, restrict physician choice. And the number one thing we believe, first of all, is that physician choice is a really important aspect of access to care and health equity, right? Because people, especially with primary care, especially with seniors, they want to go to see the physicians they've seen for a long time. And it's the physicians they trust. And trust is such an important part of making sure that people look after themselves and listen to the advice of their physicians. They want to see physicians in their local community. They want to see physicians that maybe they went to as kids, even if they're, well, not as seniors, but they brought their kids and grandkids too. So when we see this, we believe that we want to make sure that people can go see the doctors that they want to see. The second dimension is what I call a physics of healthcare issue. I think most people will agree we don't have enough doctors as it is, right? And so if you don't have enough doctors, if you are just narrowly thinking about the problem, you're like, well, okay, fine, I can narrow my network because I just look after the people I have. But as a society, if we want to run our whole system on narrow networks, well, how can that work? You don't have enough doctors, even with 100% of the doctors. How can those subset of doctors look after everybody, right? And also, these high performing groups tend to be concentrated in certain areas, in urban centers, and in wealthier neighborhoods. That draws a geographic circle around the people who can see those doctors. That's not good for health equity. That's not good for fixing healthcare in general. And thirdly, speaking as a business operator, I would say healthcare is seen as a very regional problem, and it is, but the total addressable market is everyone who needs care in the US. We see our total addressable market as everyone on Medicare, right? And we don't want to just draw circles around certain provider groups and say, well, we want people who live within 5 miles of this group and 5 miles of that group and 5 miles of that group. We say, how can we service everybody? How can we service everybody no matter where they're living, no matter which doctor they're seeing? And so that's why we believe in the wide network. Maximum choice, maximum trust, because you can pick your own doctor. You don't feel steered or moved into a certain doctor by a health plan. And you can actually say that we want to look after as many people as we can within the US, not just be a regional plan. You see that in the way that other plans are launching their own capabilities, and they say, well, how do we partner with a national provider, or how do we partner with more folks outside of our home region? Many plans who have those narrow HMOs try to now launch those narrow HMOs into other areas. And we think that it's much more strategic for us to base our plan on the Clover Assistant, which is our software platform, deploy the Clover Assistant to as many doctors as possible, help those doctors improve their quality. So not just select them for their pre-existing quality into a narrow network, but improve their quality, and then now have a wide network, manage quality with software, and give access to data-driven primary care to everyone on Medicare, everyone in the United States. And so that's why being a wide open network combined with the Clover Assistant software for quality and data-driven primary care, that's the core of our approach.
And when you're thinking about network strategy, I mean, could you just talk a little bit more about why this makes sense in Medicare, kind of given the complexity of that population?
Yeah, absolutely. So a couple of different things. First of all, We are a Medicare Advantage plan, and oftentimes people segment the Medicare Advantage plans into saying, well, your market is Medicare Advantage. We say our market, like I said, is Medicare, like the way you put it just now. It's the seniors who are on Medicare, and we want to serve all of those seniors, right? Those Medicare eligibles. A lot of them still, about 60% of them still choose fee for service, original Medicare, right? And so if you think about that, original Medicare, they're choosing it because it is a really open network that gives you a lot of choice of physician, anyone who accepts Medicare, and you can go between states, you can move around, and you don't need referrals, and people really, really like that. A lot of people still pick it. So we don't see ourselves as just a Medicare Advantage plan. We see ourselves as a Medicare company. We participate in Medicare, a fee-for-service now, through the direct contracting program. And the fact that we are based on software and based on open networks at our core allows us to go into original Medicare. So that's always existed, and I think it's a benefit that's really already appreciated by those who are on fee-for-service. The key is the fee-for-service network is a little bit, someone once said to me, it's a little bit like the wild, wild west, right? They're in there, they're not centrally managed, and that's normally the criticism of that open network. Well, the thing that brings that together for us is the Clover Assistant, right? We're never telling physicians ever how to practice medicine. That's not our job, to tell physicians how to practice medicine. We don't acquire physician groups. We don't push our protocols on them or anything like that. What we do is we use Clover Assistant to bring evidence-based care, evidence-based data-driven care to the physicians who are using that. And they might be using it within fee-for-service constructs. They might be using it within our open network PPO, but that's what brings consistency. So I think we're trying to get the best of that choice from fee-for-service, bringing it with the more control and standardization of evidence-driven care that you can find in MA, and create that hybrid best of both worlds.
You just mentioned, the Clover Assistant and the tech stack that you have at Clover. I mean, how critical is technology to being able to offer this kind of broad network approach?
Absolutely. So something that I often, so my background, as you know, as people might know, I come from the technology side. I'm an engineer by training. And so I've been quite used to looking at various industries and saying, well, how can technology augment and improve the way that this industry delivers its capabilities? And healthcare is no different. The one thing, though, I would call out is, and people say this all the time, is like, oh, well, you're in a health plan, you must be building a lot of insurtech. We actually don't build a lot of insurtech. We invest in technology there, but it's best of breed, being cloud native, being agile. Basically the top edge of having the greatest insurtech technologies. But that's not where we focus our research and development. We focus our research development on clinical technologies, which I think is even more unusual to some extent for a health plan, right? So we go and say, we don't want to, like I said, tell physicians how to practice medicine. So what we're doing with the Clover Assistant is not trying to be a better doctor than the docs. We want to let the docs do what they became a doctor to do, practice medicine. And what I like to say is, everybody can be a better form of themselves if technology gives you data, right? Gives you personalized and specific data. Then every human, including physicians, can become a better form of themselves. It's like getting superpowers, right? So an analogy to the Clover Assistant that I use is, it's like GPS, right? And so, if you ever try to convince somebody to use GPS who maybe has been living in a town for a long time, maybe your parents, oftentimes they say, well, yeah, I don't need GPS. I know this town, I know these roads, I know how to get around. But we all know that if you just say, listen, just have it on, just turn it on when you drive places, you don't have to follow its directions, you know how to go around. But there's data in that GPS, right? There's there's a car accident ahead. There's traffic, there's disproportionate traffic ahead. Something is happening. And when given that data, even someone who lived in that town for 20 years will say, oh, I didn't know that. I'll take a different route in that case, right? That's the way I think about technology, is we're arming physicians with data, personalized data, information about the patient, information they wouldn't have in their EMR, evidence-based protocols from the latest studies. We don't do the studies, but evidence-based protocols that say, there might be a drug interaction, right, between these two drugs they're taking. Even more specifically, and this is very much in discussion these days, maybe from certain demographics, certain ethnic groups metabolize drugs differently than other ethnic groups. And we've traditionally had very broad brush strokes that physicians, the clinical protocols have said to prescribe. We can get more granular now with Clover Assistant and say, I know you put them on this drug regimen. Have you seen this study that says for this demographic, maybe this other drug is better, or maybe the drug dose level might be different? So you can practice more granular, I don't want to say precision medicine because that's a loaded term, but I like to say more personalized medicine, right? Going through here. So I think that's technology's role, to bring together an enormous amount of information that's out there these days, more than any human being could really just have time to digest fully, but point you to the places where you should look, and then you use your human brain to make the important decisions about care and about all the things that doctors are great at.
And you just said, that this allows you to really kind of personalize data and the care, get into some of the more individual needs for your members. I mean, when you're thinking about, your approach to networks and the technology stack that you have, how does that let you maybe get at health equity challenges or health disparities that you might see among your membership?
Yeah, I think that's a really, really important dimension of how everyone should be thinking about care, about how everyone in our industry should be designing their technologies, designing their health plan products. It's just got to be something that's top of mind for all of us. And so the way that I think about it is, number one, we talk about how open networks let people see the physicians that they trust. And especially for primary care and for seniors, what we see in our surveys and information, and it's probably intuitive to a lot of us as well, that if they have a primary care doctor, that's really the doctor they want to see, right? You don't really want to walk in and say, listen, yeah, I know you've seen this doctor for 20 years, but I've got a better doctor who's in network. Why don't you go see them? Even if my data says they are better by quality metrics, and I'll get to physician quality metrics in a second as a second part of my answer, but let's take that at face value. Even if we say that they're better, they generally don't want that, right? That's not what they want. And when you start to break down that trust wall between them and their physician, they become less compliant, they become less open to hearing about care, and that's not good for anyone, right? So from a health equity perspective, we see that people want to see their doctor within their own community, within their own neighborhood, maybe within their own ethnicity. This is just how human beings work. And because we're not robots and we need that trust with the physician, it's important to let them pick their doctor. So that's number one, right, from a health equity perspective. Number two, what we believe is that I think accidentally, a lot of health equity a lot of physician scores that a lot of health plans then use to select physicians within their network, perhaps accidentally, actually leave out but a score physicians who serve underserved populations very low. So I'll just give you an intuitive statement that probably hopefully sounds right. The higher the percentage of people on Medicaid within a physician panel, in general, the lower their scoring on independent physician metrics. Like not our metrics, I'm talking about industry metrics. Like if you anyone can look into it, that's pretty much true, but I think it feels intuitively true as well, right? I'll give you an example of why that might be. Well, Medicaid pays lower than Medicare, and certainly than commercial. So you have a high Medicaid population, then you are just going to be being paid lower on a per visit basis for those physicians, for those patients, and then you end up sort of like taking more because you can't afford to have cancellations and gaps in your schedule. So those physicians will overbook their schedule to try and make sure they're filled and they don't have any wasted time during the day. But that affects waiting room times. That affects cancellation rates and reschedule rates, right? Something as simple as that. And then what happens is fewer physicians then start to take Medicaid. Few of them serve those communities, which means even more pressure on the doctors who do take Medicaid patients, which means a cycle of lower scores. Then they start to get dropped from the network of the commercial plans because they're scoring low. Now they have to take the Medicaid. Like it's a cycle, which makes it very difficult. But where are these patients going to go, right? You can't just say, oh, well, let's just not worry about that. It has to be solved by somebody. And what we need to do is reward physicians fairly for serving the underserved, not punish them or have better metrics that take that into account to accommodate for that. And we as a healthcare industry and as a society are not doing a good job of doing that, right? And so from a health equity perspective, if you just think of it not just as equity, but as access to care, access to great, convenient, affordable care, right? That is putting a lot of pressure on the lower socioeconomic groups, a lot of pressure of those who live in high area deprivation index areas. If you look at those geographic areas that have high area deprivation index, so basically meaning they're lower socioeconomic groups, fewer doctors, harder to get to. It's kind of an analog to food deserts, not quite, but if that makes sense, like it's a little bit of an analog. You got to travel further to get to a specialist. And then even then, maybe if you have a narrow network, maybe even further to see a specialist. So this is a huge part of why we believe in the open network strategy, is to help serve these people who are having difficulty accessing care otherwise. And that is part of the goal of, I would say, certainly Medicaid, but Medicare, right? Medicare is a great equalizer where society starts to pay for care, and we should all be rewarded and be rewarding our seniors for a lifetime of hard work, where they can now be looked after by us.
We're coming up on our last couple of minutes here, but before we close, I want to ask you, how you're thinking about all of this, your network approach that we've been discussing in the context of a really hot and crowded market. I mean, how do you view this as a differentiator for Clover, as you're looking at, other players around you?
Yeah, absolutely. So just speaking as a business person here, I want to say, I love being at Clover. I love building Clover because we are a mission-oriented company to improve every life, but we also want to build a great business while we're doing it. We're entrepreneurs and we're startup people, and we want to build a great business well, right? Both those things happen together. So what I would say is there's an analogy sometimes in business, which is you're a red water company, you're a blue water company. Right? I think a lot of healthcare companies, because their business are even the newer folks, not just the incumbents, tend to have red water thinking, right? It's safe there because it's known to be safe. You go there and you sort of compete with other folks, like you say, in that market because it's a known good market, right? We're more of a blue water company, meaning we're going because we see the global maxima that we think has the bigger total addressable market, which is aligned with our mission to improve every life and help everyone on Medicare. So if you ask those people, many people listening to this call, health wonks will probably say, wow, the open network, that's scary. I don't really want to run an open network plan. It's very scary. How will I have control? They'll be like, technology? And they'll say, you mean hand over the keys to the business to my IT department? I'm not doing that. That's crazy. IT is not going to run my business for me, right? Like that this will be the discussions that people will be having. Like, even if they say, oh, I believe in technology, what they mean is, oh yeah, we should probably get off the mainframe sometime soon, or we should probably consolidate our claims engine sometime soon, right? Even new incumbents take a new insurtech thinking, but take that regional view, right? Again, you can see that tight alignment to orbiting specific provider groups as a pathway to success. And that is a very successful if you are not looking for the global maxima, the full total addressable market, right? It's successful in that region. A much harder problem is to solve this on a broad basis, right? Across the country, saying, well, how do you help people in rural areas? How are you going to help people in those high area deprivation index areas where they just don't have doctors in their zip, right? Like, well, how am I going to solve that problem? Other, I think, approaches are all like, stay away from those people. Or, you know what? Don't worry about it. The clinic I partner with doesn't serve that area, so no big deal, right? And that's not the way we're thinking. You could have an approach where you open clinics in those areas. I fully support those trying to do that, but very difficult to do, right? I mean, it's capital intensive. It takes a long time to open a clinic. And again, even if you open a new clinic, you don't have the years of trust that the local physicians have with that community. You're seen as like a interloper coming into that community. Very difficult to do. So that's what we see as our opportunity. Very difficult problem, don't get me wrong, extremely challenging. You have to kind of take a blinded leap of faith to put your to run your plan on technology, right? You can't be like, yeah, we love tech, but actually I sell all the risk to the providers, right? You have to be like, no, I'll own the risk. I'm going to run it with my technology. I'm going to run it with data. I'm going to truly believe that works. And if I succeed with that, that lets me have a scalable program. I can launch it anywhere in the country. I can launch it with any doctor. I'm not constrained by narrow network. I'm not constrained by those physicians who are sophisticated enough to take risk either upside or downside. I will be able to actually create better outcomes, lower costs for the government, all of those things.
Well, great. Andrew, thank you again so much for joining us. And thank you to everyone for tuning in. Bye bye.
Thank you so much for having me.